Soumitra, I am Dr. Kar. I have one just question to you. Now, it is a common experience in our practice that patient is heart failure with reduced ejection fraction. Patient is on optimal dose of AC inhibitors or ARBs, beta blockers, and MRAs plus diuretic, and patient is stable. Previously, patient's ejection fraction was 28%. Now it has improved to 32%, and patient is clinically stable, no edema. Now, in this patient, you like to switch over to ARNI, or you like to add SGLT2, or you like to keep add both. I mean, switch over to ARNI and then add also SGLT2. What will be your option in this type of patient?
In fact, we are progressively giving up the practice of starting with ACE inhibitors or ARBs in the first place.
Let
Why
me
not
finish.
ARNI in the first place? Because based on the pioneer heart failure and transition trials, after the initial stabilizations, we have now got the license to start ARNI as the first line of agent from the group of RAS blockers and neprilysin inhibitors combined. So I think ARNI should come in place of ACE inhibitors and ARB straight away. Why use them at all? Unless, of course, the cost factor, again, which is progressively being taken care of by launching of the indigenous brands. So once the cost factor goes, I think ARNI is going to replace ACE inhibitors and ARBs in heart failure. And coming to SGLT2 inhibitors, I would say that in many of my patients, there are limiting factors for use of either RAS blockers or ARNI. It is in terms of their renal function, their potassium levels, and their blood pressure. So in many of my patients who are very ill with the kind of ejection fraction that you mentioned, I am not being able to start these molecules at all before discharge. So once patients are stabilized, they are euvolemic, and they are, if they are diabetic, their diabetes or insulin requirements have been taken care of. Why not start SGLT2 inhibitors also before discharge, irrespective of their diabetic status? So that is my line of thinking.
Okay, Arup,
Dr.
you have got
Kumar,
any opinion?
yeah, not opinion. I'm just asking another question to Dr. Kumar. First of all, Dr. Kumar, congrats for a wonderful talk and summing up the SGLT2 inhibition in heart failure. Now, maybe I am throwing a bit a silly question. That is, in view of the good and robust evidence base in DAPA-HF and Emperor reduced, do you have any choice between DAPA and EMPA in heart failure situation with or without diabetes?
Uh, Not really, except for the cost factor. Again, as you know, one of the molecules you just named has apparently gone off patent. I'm using the term apparently because I understand it is still sub judice. Some people claim it is still sub judice, but there are so many Indian brands of dapagliflozin that is available now. So the cost factor, which has been an impediment for us as clinicians in using this group of molecules, has gone. So if cost factor is not there, on the basis of science, it is either of the molecules, because both the trials have been fantastic and the trends towards benefit have been along the same lines. So I have really to choose between them. But when the cost factor comes, yes, DAPA is
May I
obviously.
just point towards one issue, though these studies do not belong to this dedicated heart failure. In EMPEREG, the outcome, the original one, there were established cases of CAD who bettered with EMPA. So, do we have a choice there? Because heart failure, if we find to be the established cause of atherosclerotic arteriovascular disease is there or something, can we go for EMPA choice due to reduction in mortality as well as morbidity?
Yeah, very pertinent question. But you see, each trial is different. Trial populations is different. In
No, they had
EMPEREG,
also heart failure improvement.
I'm just trying to answer your question. In EMPEREG, we had the very fascinating reduction in cardiovascular mortality, which we did not see in declared TIMI, even in the secondary prevention group to that extent. But here in DAPA heart failure, on the reverse, we could see a more impressive cardiovascular mortality reduction compared to Emperor Reduce, where cardiovascular mortality reduction was only 8%, if I remember, and it was 18% in DAPA heart failure. So you see, each trial is different, trial populations are different. I personally believe these are definitely class effects, at least for the time being. these effects are seen with both DAPA and EMPA. So I have really, on the basis of science, little to choose between them.
No, we are Soumitra. What Professor Arup Dasbishya said, I think rightly, that you see, in patients who are having established coronary artery disease, and EMPA definitely has showed the significant mortality benefit, which DAPA did not show. Mortality benefit, cardiovascular outcome mortality benefit has been definitely shown by EMPA in patients who are having established atherosclerotic coronary artery disease. In that way, what Professor Dasbishya is asking, in patients who are having established coronary artery disease, he like to give EMPA rather than DAPA with heart failure.
Soumitra, one point I have to say. Yes, just about hearing you.
Yes, yes.
Yes,
Yes, Soumitra?
Yes.
just missed one.
I think Dr. Soumitra is speaking. Yes.
I have missed one very important slide from your lecture, the canvas studies, canvas of canagliflozin, and they're showing the similar effect of heart mortality and heart failure effect in this case of. And the number two question, would you apply SGLT2I in the heart failure in non-diabetic patient?
Yes, of course. I mean, yes, of course. I read out the European guidelines for you. They have recommended SGLT2 in symptomatic heart failure, irrespective of the presence of diabetes. Irrespective of the presence of diabetes. So it can definitely be used. And it should be used.
You have not mentioned the canvas study of canagliflozin.
Canagliflozin was not really a heart failure study, but again, like EMPA-REG and DECLARE, in fact, all the SGLT2 trials, heart failure hospitalization was a uniform effect seen in both patients with cardiovascular risk factors and in patients with established cardiovascular disease. So heart failure hospitalization has been the common factor in all the SGLT2 studies. So that way, I only talked about patients of dedicated trials of heart failure with disease. That's why I did not speak about canvas. But yes, in canvas, canagliflozin also showed a remarkable decrease in heart failure hospitalization.
Thank you, Dr. Kumar. If you have finished, we have to wind up.
Yes.
Yeah, I think we have limited time. So I would request Professor Kaur to take up for the next session. There are 3 speakers more left. And I thank Dr. Kumar for a very beautiful speech. I shouldn't say oration. Yeah. Ashudha, handed over to you.
Yes. Thanks, Dr. Dasbishya. I think it's a very exciting program is going on echocardiography. And today we have got an eminent speaker, Professor J.C. Mohan from Delhi. And I think Professor J.C. Mohan do not need any introduction to all of us. And he's going to speak on a very important subject, that is LA strain or LA function in management of heart failure. What is the role of LA function? How we are going to detect it by echo? What are the newer methods? And how assessment of LA function helps in the management of heart failure. Professor J.C. Mohan, please.